Hello, welcome. My name is Nicholas St. Fleur. I am a general assignment reporter and associate editorial director of events at STAT. I am also today's moderator. Today's forum is presented in partnership with the Commonwealth Fund and jointly with STAT. Joining me today are Mary Feindling, Assistant Director of the Harvard Opinion Research Program, Lori Zephyrin, Vice President of Health System Equity at the Commonwealth Fund, Alden Landry, Assistant Dean for Diversity and Community Partnership at Harvard Medical School and Assistant Professor of Emergency Medicine at Beth Israel Deaconess Medical Center, and David Ansell, Senior Vice President for Community Health Equity for Rush University Medical Center, and Associate Provost for Community Affairs for Rush University. We are streaming live on the website of the forum. We are also streaming live on Facebook and YouTube. Viewers can submit their questions via email to theforum@hsph.harvard.edu. Again, that is theforum@hsph.harvard.edu. Today, COVID-19 is shining a light on health inequity, exacerbating long-standing health disparities, and forcing Americans to confront a legacy of medical mistrust born of generations of racism and bias. Whether we're talking about COVID-19, maternal health, or cancer screening, the fact is that people of color often have a very different experience of the healthcare system, from the doctors and hospitals they access to the seriousness with which their providers treat their symptoms, to actual health outcomes. Today, we'll examine the intersection of race and healthcare delivery, acknowledging that healthcare doesn't exist in a vacuum, but within larger systems and structures. And we'll discuss how these systems can either sustain and widen health disparities or be transformed to bring about greater health equity. To help us understand, let's take a look at a clip from a mini documentary called Stories of Black Motherhood, courtesy of M Vision Productions. And when you watch this clip, I encourage you to remember that according to the CDC, Black women are 3 times more likely to die from pregnancy-related causes than white women. Thank you.
As a woman of color, when you are at the hospital, often you feel a bias.
Going back and forth with all of the nurses, one of them came in and was like, saw my husband and was like, oh, she's gonna have beautiful curly hair. And I was just like, oh, I don't want her again, and just, I was banning nurses left and right. It was my only saving grace was that my OBGYN was Black and understood. She understood that I was under more stress than the other women that were on the floor. She understood that I needed injections of Blackness. She came by with poems and songs, and she just sat and talked with me. There is something really powerful about a well-placed girl. Like, that is, as soon as she said that, I was like, oh, okay, I'm in a space that, like, I can be all of me, right?
Wow, I love that, injections of Blackness, and goodness, I've done a bit of reporting in that area, and so much of what she relayed really rings true to some of the experiences that I've heard about. Mary, we just heard 2 women of color share their patient experiences. You recently helped lead a national survey of Black and Latinx households, looking at their personal experiences with the healthcare system. Tell us about what the poll found.
Thanks, Nick. I'm here to talk about the public opinion side of racism in healthcare delivery this morning, and what the public thinks, as well as Nick mentioned, what patients say that their experiences have been. So if we pull up the first slide, we'll see that though most of the audience today watching probably already recognizes that racism is a very serious problem in the United States, the general American public is actually much more split in their views on this issue. I'm a survey researcher at Harvard, and we pulled on this recently and found only 47% of Americans believe racism is a very big problem in the country today, which means that 53% don't say this. This number is much larger among racial and ethnic minority communities who widely identify racism as a very big problem in the country today. And so in the middle of this big public debate, we wanted to capture what Black and Latino patients are experiencing in their everyday lives, because there really is quite a difference between people's general views and what's actually happening in their day-to-day. And this poll, this type of poll is actually quite unique to examine racial and ethnic minorities' life experiences across the nation and in healthcare specifically. And that's what we focus on in a poll that our team at the Harvard Opinion Research Program, along with our partners at the Commonwealth Fund, conducted in November and December of 2020. This was a nationally representative poll of around 1,200 Black and Latino households, really meant to learn more about patients' recent experiences with racial discrimination in healthcare. So if we pull up the next slide, there are really three findings from this poll that I would like to emphasize. The first one is that experiencing racism in healthcare is unfortunately quite common among Black and Latino patients. So nationally, we see here that more than a third of both Black and Latino adults in the United States say that they or household members who'd received care in the past year experienced one or more forms of racial discrimination when they got care. And if you think about the broader picture here, if you are in any type of service industry, if you work for an airline, if you work in retail, or if you work in healthcare, and a third of your customer base is telling you that they've experienced racist behavior from you in the past year alone, that should give you pause. If we pull up the next slide, the second major finding that I'd like to emphasize here is that when you dig into what these discriminatory experiences actually are, they're often subtler forms of racism that may be overlooked by providers. Nationally, about 1 in 5 Black households and about 1 in 8 Latino households who've gotten care in the past year say they were overtly discriminated against at the doctor's office because they are Black or Latino. And so that's overtly racist care being received by millions of Black and Latino patients. But then come the subtler forms of racism. So about 1 in 5 Black and Latino households say in the past year they were not offered the best available treatment. About 1 in 8 say they've been denied timely access to needed healthcare services. And a similar share say they were not referred to see specialists when they felt they needed a referral because they were Black or Latino. And so there are a myriad of experiences here that Black and Latino patients are reporting that are racist in nature, right? That is, this is substandard care, and patients are saying this is happening because they were Black or Latino. And then in the next slide, the third major finding from this poll that I was really surprised by is how broad this problem is throughout the healthcare delivery system. So this is not just happening at the ER. This is not just happening at a neighborhood health clinic that racism is a problem. It's occurring everywhere. Between 1 in 10 and 1 in 12 Black and Latino patients reported discrimination at any different types of these providers, really underscoring for us how widespread this problem is in healthcare delivery. Discrimination cuts across all different institution types, provider types, and interaction types with the healthcare system. And Nick, I'll throw it back to you.
Mary, thank you so much for sharing your findings. Those are pretty insightful. I now want to ask, turn it over to Lori. Lori, the Commonwealth Fund has also been examining these issues. Tell us more about where you see opportunities to shift the culture and bring about greater health equity.
Thanks, Nick, and thanks, Mary, for sharing those really powerful results with everyone. Commonwealth Fund, is a foundation dedicated to achieving affordable, quality healthcare for everyone in the U.S. And like everyone participating in this session, we recognize how urgent it is to name racism, confront racism and discrimination in U.S. healthcare. And so that's why at Commonwealth Fund, we focused our efforts on people who've long been denied access to healthcare and other critical services. The work that I lead centers on efforts to dismantle systemic racism in healthcare policy and practice and counter inequity in treatment, in patient experience, and in health outcomes for Black people, Indigenous people, and other people of color. And that work is really informed by decades of work that I've done as an obstetrician gynecologist, which has shown me how important it is to examine patients' recent experiences with healthcare from their own perspectives. Mary highlighted this really important work that we've collaborated on, which highlights, that the importance of data and capturing lived experiences in health inequity in the U.S. and the impact on, not being offered best available treatment, or being denied or delayed access to needed healthcare, or not being referred to see specialists, for example. And we have other surveys, for example, with the African American Research Collaborative, that has documented how experiences of discrimination impacts people's confidence with getting the COVID-19, for example. And I've seen and heard experiences like this from time and time again. And having data like this that's disaggregated by race and ethnicity is important, because it makes inequities that exist in our society and healthcare system, it makes them visible. And it's something that we can point to, and something that we can compare and address. As a healthcare professional, I understand that fixing racial inequities seems daunting. It is daunting, but there's so many ways in which we can shape health, including thinking through how people pay for healthcare, how people experience healthcare, and really thinking about how ensuring that the healthcare system provides equitable quality care, and acknowledging how patients are able to or not able to access care. And measurement matters. What we measure is what we value. And the reality is we can't improve healthcare if we aren't accurately measuring and tracking these inequitable experiences, or inequitable treatment, or inequitable outcomes. And we have to use data as a guidepost to really hold ourselves as the healthcare system accountable.
Wonderful, Lori. Thank you so much. Alden, as a physician in the emergency department, you're seeing patients who are often in moments of medical crisis. Tell us about how health inequities play out in the emergency room, and where interventions can have the biggest impact.
So I love the juxtaposition of having data as well as patient stories. And I think we've heard some great data to talk about patient experiences with healthcare. But I think I can probably interject a patient story that will really help to bring together this conversation a little bit more. So early on during my training, I remember caring for a patient in the emergency department, and part of care in the ED, especially when we get busy, is taking care of patients in hallways. And I distinctly remember caring for a patient in the emergency department. He was placed into hallway 1, which is probably the busiest intersection within the emergency department, because everyone flowing in and out of the emergency department, whether you were walking in or you were being brought in by ambulance, you had to go by hallway 1. And this patient was placed there at the beginning of my clinical shift in the emergency department, and for the entirety of his care in the emergency department. And at the end of my 8 or so hour shift in the emergency department, he was still there, about to be admitted to the hospital. I was walking by him one last time as my shift had ended, and he was about to go upstairs. And we had a brief interaction that really stuck with me and has really helped to shape my career, but really my thoughts around health equity in not only just emergency medicine, but in medicine as a whole. And in our brief interaction, as I was about to leave and he was about to go upstairs to be admitted, he stopped me and he asked me a question. And my assumption was his question was going to be about whether what his condition would be, or if he needed more pain meds, or if he needed something simple as a pillow or a blanket. But instead he asked me, "Hey doc, why did they put all of the Black patients in the hallway?" And it was the first time that I, who was a part of the healthcare system, where I was caring for patients in the hallway, where I was caring for patients throughout the emergency department, actually stopped to realize that I was operating within a system that was showing bias against certain patient groups. And what we did was, when I heard that story, obviously I tried to console the patient, answer his question appropriately, but I recognized that the patient was pointing out the flaw in the system. He was pointing out the racism in the system. And so I brought this up to leadership within the institution. I brought this up to leadership within the emergency department, and we had a conversation about whether this is true or not. And I think it gets back to Lori's point about having the data. And we actually ran the numbers. And unfortunately, from a quality perspective, when we looked at the data, when we looked at the way we were caring for patients, there were certain subsets of patients who were being placed in the hallway compared to others. And it tended to be our minority patients, those Black and Latinx patients, patients with limited English proficiency, and then also patients who are homeless or unhoused. And it just showed that there was bias with the emergency department. And these are typically things that we see when we're collecting data that we're going to be reporting back to CMS or the Joint Commission. But these are the real experiences that our patients are having when they come to our healthcare systems. And so I think it's really important that while we look at the big data that we're expected to collect, whether it's those things where we have seen bias like door to EKG times or access to pain medications for long bone fractures, we know that those disparities exist. We also need to listen to our patients more and understand that their experiences, when they express frustration within the healthcare system, it's not just that they were a grumpy patient or they had a bad patient doctor interaction. There's actually oftentimes more to the story, and it's really important for us to go back and tease out the numbers and see where our patients those complaints are coming from, and think about how we can address the potential blind spots that we have as healthcare providers that are actually pointing out racism.
Alden, thank you so much for sharing that and for your openness with that anecdote. It is eye-opening, and I'll be sure to ask you some more about that as well. I want to ask, turn to David. Alden just gave us some insights into what individual departments and physicians can do to improve health equity. You've written about the need to adopt a system strategy. Tell us more about what that means and why it's important.
Yeah, these issues are both internal to organizations and external to the world that we're in, but they're also internal to us. And you can be a white physician or a Black physician, be parts of these systems. We've taken on at our organization the idea that if we're going to dismantle racism in these systems of oppression like racism and economic deprivation, we must have a strategic approach to doing so. And that strategy, we wrote about it in an article in New England Journal of Medicine Catalyst, laying out the strategy for RUSH, but I do think it lines up to be a potential national strategy for this work. And it starts with naming and eliminating racism, and naming it both institutionally but personally, and particularly for white leaders, white physicians, to learn to make what's been invisible to them and many of their colleagues visible. The second part of the strategy is to adopt an anchor mission. And that mission is to leverage the economic power of healthcare institutions to address the deprivation that's occurred in neighborhoods outside their doors by hiring, by creating career pathways, supporting local businesses, and other types of things, investing in these neighborhoods and volunteering in these neighborhoods, a form of restitution for these injustices, providing wealth-building capabilities for the employees, many of them who come from these neighborhoods, allowing people to move into wealth, into leadership, eliminating healthcare inequities, and then addressing the social and structural determinants of health in these neighborhoods and places by partnering with community in an authentic way to address these historic injustices. So that's kind of been our approach strategically, and we call it an inside-outside approach. But for me, the personal side of this, and I love what Mary and Alden and Dr. Zephyrin said about data plus story. So narrative plus data plus action equals change. And for me, my career, I came to Chicago to work at the public hospital, Cook County Hospital, and I spent 30 years in the safety net institution of Chicago before being recruited to Rush, an academic medical center, as the chief medical officer, the inaugural one. And my patients came with me. And literally along one street of Chicago, I call it one street, two worlds. There were two worlds of health and health outcomes. And as a white doctor and my patients, we did a litmus test on the state of the healthcare system. And it's an apartheid healthcare system. There's different hospitals, different systems, largely for Black and brown and poor people, and a different system for those who have more, and is segmented with white on top and Black and brown on the bottom. And I observed this, but it took me many years to speak about it. And I realized I had a personal obligation as a white doctor, as a leader, to name racism as an affliction, as a form of oppression and economic deprivation, not poverty. Poverty is a state, economic deprivation is a force. And it's really important to name the problem clearly, because how can you fix a problem if you don't name it? I was a chief medical officer at Rush, and someone got sick in the hospital. You always do a root cause analysis, because if you don't get the root cause right, you're going to fail again at it moving forward. And I remember talking to my CEO and saying, the root cause of these poor health outcomes is racism and economic deprivation. Therefore, we have to take it on. But it starts by speaking about it. And then once you name the cause, that you get 1 point in the world for doing that and 100 points for actually trying to fix it, you've got to go to the figuring out how to solve it. And a lot of that has to do with how is the decisions about power, resources, and money distributed in our communities and within our institutions. We're used as doctors to treating diseases and bacterial infections or this, but what if the affliction is racism? What if the affliction is economic deprivation? What is our obligation to think about fixing them? And then acknowledging that it was our responsibility, that these outcomes, we were ranked #1 in quality in the United States. People are literally dying outside of our doors for diseases that are quite common that we know how to treat. And so we need to think of our obligations. Healthcare institutions is beyond our door in the community, getting to those root causes. And that requires dismantling. And that's not an easy task because this is a self-perpetuating system of oppression. It's not like it happened 100 years ago, 60 years ago, 10 years ago. It's happening today, as Dr. Landry pointed out, in all of our systems, as Mary pointed out, in people's experiences. So that's kind of our job, is to think about this strategically, but that personal piece of it, because most of the leaders of our institutions, we have an apartheid health system, are white men still, and we've got to make these changes at our boards, at our senior leadership, to move a strategy like this ahead.
David, thank you so much for your input as well. So we're going to dig a bit deeper into these important insights. But before we do, I want to remind our audience that this is the forum at the Harvard T.H. Chan School of Public Health, presented in partnership with the Commonwealth Fund and jointly with STAT. And if you have any questions that you'd like for us to answer, please send your questions to the forum at hsph.harvard.edu. Again, if you have any questions and we'd love to answer them, send your questions to the forum at hsph.harvard.edu. Now, I want to talk a little bit about, some of my own reporting. During the pandemic, I've done a lot of reporting looking at, vaccine hesitancy within the communities of color, mostly before the vaccine was first developed, looking at doctors who were kind of gauging the scene, trying to figure out what the uptake would be like, looking at some of these systems and events that have led towards, medical mistrust. Hearing these stories about, vaccine hesitancy, they point to this bigger, deeply embedded and long history of structural racism in the U.S. that plays out in our healthcare systems, that has been there for a while, but it also plays out to experiences that people have every day with the healthcare system. It's not just these events like Tuskegee and Henrietta Lacks. It's people who have family members who went to the doctor and didn't receive the best form of healthcare that they felt that the doctors weren't listening to them. All of this different types of impacts. Rooted in racism in the healthcare system. And one area that, people discuss a lot is implicit bias, especially amongst, healthcare providers when they're trying to understand these issues within healthcare. And I'd love to kind of pose as a question to the group as we kind of start our discussion, what kind of impact do you feel implicit bias plays towards racism in healthcare? And in addition to implicit bias, what are some of these other forces that are really exacerbating racism within the healthcare system? Anyone who would like to kind of jump in can go right ahead.
I can start. I think
Mary.
Implicit bias is one element of what's happening, but I think the danger here is that there's been so much focus on implicit bias training as the solution when there's not really good evidence that it works. And so I think that really takes the focus off of the need for broader institutional change, like David was discussing, and really just bigger changes beyond, that have more imagination to them beyond individual training, which are what the data are telling us that we need.
And I would add to that, I think that implicit bias training is sort of the hot topic of the day. I think we have to really dive deeper into the issues that are happening around medical education. I think the way that we teach medical students is important. We have to make sure that we're having more deeper dive discussions around structural racism within medicine, understanding the history of where medicine, the way medicine is practiced, having a better understanding of the structural or social determinants of health, and really having that as a central component of medical education, so that when a patient walks into the hospital, we know that they're receiving care from a provider who has had that sort of next level discussion when it comes to these issues. I also think that we often focus on physicians as if we fix the problem with physicians when it comes to implicit bias or racism, then we're going to fix the entire healthcare system. And I think the reality is it has to go further than that. We have to look at nurses. We have to look at technicians. We have to look at frontline staff. We have to look at everybody who comes in contact with patients, because each of those individual experiences can help, those interactions can have a positive or negative impact for that patient's experience when they walk into the hospital. And so, our registration technicians, those folks who are meeting those patients when they walk into the hospital, are they treating patients fairly? Are they being appropriate? Are they showing, are they being rude, or are they, being dismissive? Or, when a patient calls in to schedule an appointment because of their, whatever it may be, whether their language or their insurance status, are they getting equal access to care? And we need to think about the entire system, not just thinking about it from a physician provider standpoint.
If I might add, in this, there's an expression in medicine: what the mind does not know, the eye does not see. And so, in a sense, I don't want to dismiss training totally, but we've got to get people to see, so it's quite common, as Mary described, that people experience everyday discrimination. Black and brown people, women, others. It's not just limited to that, but people experience everyday discrimination. White people in general walk through the world as if we can walk through walls invisibly. I never looked, when I got to Rush, I never looked at it as a big white tower, as a white space. But for people who walk, most white people don't imagine walking into a space as being a white space, but they certainly know when they're walking into a black space, and oftentimes won't walk into them or avoid them or go to them. So what we've got to actually do is do this awareness piece. We actually got to change the way that we all act. So think about, even in a hospital, going on rounds, before you walk in the room with your team, how do you acknowledge that this everyday racism exists? And as we walk into the room with that patient, what does that mean for how we need to act and listen? And there's ideas out there like structural humility, like really asking questions about and engaging. So we have to get from training to praxis. I do want to mention a big idea, and it's from my colleagues, Bram Wispley and Nichelle Morse in the Boston Review, about sort of the framing this in a way too. And they talk about the healing arc, and now it comes out of ideas of reparations, restorative justice. And so they say 3 things are necessary for us to do writ large. Number 1, there's got to be acknowledgement that injustice not only has occurred, but is occurring today in our midst. Now, maybe we don't measure it all and don't see it all, and certainly we need to use that measurement to do it, but we have to acknowledge as Mary showed us, it's occurring in our midst. We don't need more studies. We don't need more panels. We need to get to the action steps here. So acknowledgement by the leaders of the organization. We put it in our report, 2016, the root cause of the problem was structural racism and economic deprivation. So you not acknowledge it, but more important even than acknowledgement is what does it mean to redress? That's the AR in the healing arc. Redress means it's not enough just to remove the race from the race-based calculator. You've got to now call up your patients who've been harmed and then provide restitution. So if the people are being held in the waiting rooms, ED, how do we preferentially make sure that they're getting rooms? But we need to do that publicly. It can't just be a silent thing. It's not enough just to remove. We must do redress. And then there's got to be closure. And closure only occurs when the community that's been harmed historically, it gives you the dispensation to do this. So we've got to apply these frameworks of restorative justice, of restitution. I call it repair is the verb to our work.
Thank you, David. I want to move on to this kind of theme of, data and measurement here. So Laurie, as we've been hearing, there are many factors into how racism manifests in healthcare and in health outcomes. How do we get the evidence to change policies? And you said that we what we measure matters because it shows, what we value. I'd love to kind of delve into that a bit more.
Yeah, thank you, Nick. And I echo the comments previously by my colleagues. Yes, it's become increasingly clear and unveiled to many that health inequities are a substantial problem in the U.S. But many don't really have a clear or deep understanding of it, just as Dr. Ansel had mentioned, and don't understand what's fueling it, how wide-reaching the impacts are, or what could fix it. And so that what makes the need for data and measurement all the more important. It really allows us to connect the dots in a way necessary to help garner support and create blueprints needed for reform, for example. Collection of hard data that segments outcomes by race, ethnicity, and other data. It's not commonplace. I mean, as we see early in this pandemic, the lack of data early on and the challenges with that, and still challenges getting data disaggregated by key indices, including race and ethnicity. So this data gap really limits our awareness and ability to implement equity-focused interventions, and really also establish accountability mechanisms that strategically address health disparities. And it's really important to say, like, segmenting and measuring health outcomes by race and socioeconomic condition can be a starting point, but it rather than the end goal, because measurement, as you hear on this conversation today, measurement alone is not sufficient. We need to be able to target investments, create accountability, so that we can actually have action that we need to advance health equity and eliminate systemic racism. I think there are a couple of key elements that would be helpful to illustrating the scope of how racism manifests in healthcare. One, a mechanism for patients to routinely provide feedback about personal experiences with discrimination, collecting this routine information that would allow individual healthcare organizations to track their own progress and benchmark themselves against peers. And it's also real important to build this evidence base for how racism manifests within healthcare. And then two, transparency. Results from surveys about discrimination should be publicly reported. Could this incentivize individual healthcare institutions and medical practices to figure out how to, address and reduce racism strategically? I think also the transparency can help enhance structures and processes and outcomes of care and pinpoint areas for improvement. We're supporting projects, for example, that seek to understand, beliefs about race and health and ideologies around health and healthcare, for example. One example, we're working to be able to capture and document such beliefs, which can allow us to better understand how the equity impact of policies and how racist policies are formed, for example. We're currently supporting the development of a racial data tracker and racial policy tracker, to be able to collect data on policies and evaluate the effects of these policies, right? And to ensure that this information can be disseminated, at the state and federal level, for example. And so, we need this system to collaborate to determine what instruments we need to document patients' experiences and really create accountability to take action.
Thank you so much for that, Lori. I'm curious if I could ask a follow-up for people who might be, interested in starting to collect the data or make these measurements. Any advice on how they should even start, whether it be for the institutions or the individuals?
That's a great question. I can definitely start, and I know Dr. Ansel and some of his work can definitely talk more about that as well. We can start with, for example, there are opportunities to expand current survey instruments like the CAP survey, which is the most widely used patient-reported survey sent out by CMS, for example. Are there ways to integrate measures of discrimination or disaggregating patient experiences through these already existing services? Surveys, for example, are there, there's a lot of work around developing new validated instruments around measures of racism, measures of discrimination, and how can that be integrated into certain clinical settings. And also it's important for, healthcare systems and payers to really think through the data that they're already collecting. What are opportunities to disaggregate that in a meaningful way? And to be able to track inequities and be able to create interventions that show these inequities decreasing.
Great. David, did you have any other further thoughts when it comes to advice on starting to collect the data? Go right ahead.
A reflection and then a thought. So, my God, why did it take COVID and George Floyd to feel like, oh my God, wake up this country, right? I mean, so think about it. In HIV, we measure viral load. But if perceived discrimination is affecting 1 out of 5 Black and brown people in the United States when it comes to any one of our spaces, why are not we measuring it if it's an affliction? It's not because we don't have the tools, right? We have the tools. We just need to treat the whole body of the way we're trained in medicine is actually based on largely the field of eugenics, which wanted to make the point that there were racial, ethnic, gender differences to justify the way that we've operated our society. The fact of the matter is we have these tools. It was identified in the year 2000 and unequal treatment report that we needed to be doing this. It's 20 years later. We have the tools. We just need to start doing it. So that would be one. But we've also got to, so that's an accountability mechanism, and any organization in the country can do it. But you can't just walk in the room and look at someone and say, oh, they're Black. There are many different intersectional forms of identity, including sexual orientation and gender identity, that we need to really understand how people see themselves. So it's not just us checking the box. It's really, and the reason to do this is because we can design a better care system if we design it around what you really need and what you really want. So that's one thing. Two is we've got to make sure the voice of the people are around the table. Too often, even within our own institutions, even when we're thinking that we want to do racial justice work, we do not have the voice of those who've been harmed at the table. For patient safety, it was critically important to have those voices at the table as we're trying to address patient harm. So for people who've been harmed by racism, other forms of oppression, need to be at the table, and that's that power piece. I just want to just mention a couple things that we've done in Chicago with this, and we created a collaborative called West Side United on the west side of Chicago to get the health institutions together, partnered with the community with a series of metrics to say, what would it mean to reduce this life expectancy gap? See, and the measure of a hospital is quality and safety, but the measure in the community is how long you get to live. So we've made how long you get to live, the death gap, the focus of our attention, and we've deconstructed that death gap down to 5 causes, and holding ourselves accountable as a group of institutions to the drivers of those things, which are oftentimes social and structural and not just medical, but there's a medical piece as well. So Westside United has done that. But we're also working now, we all made a statement that racism is a public health crisis. And then we listed all the things we said. Lots of institutions did that right after George Floyd. But we've actually created a racial equity progress report that looks at how the organization is structured, what we're doing with our people, our community, and our patients, 4 domains, and a report on progress for racial equity, and then putting improvement groups around it. It's being piloted in Illinois. More to come on it. We got about 125 hospitals that are agreed to pilot it. But this sort of accountability structure has to be in place, and it needs to be public. It needs to be visible.
Thank you, David. Thank you so much for bringing that up. I want to turn it over to Alden now. Alden, we've talked about how to, improve systems and policies, but I want to take a step back to talk a little bit about, training the next generation here, the next generation of healthcare professionals. How can we improve medical education around these very important issues?
Yeah, thank you. I think that's a wonderful question, and I think it's a huge part of this discussion. But I actually want to touch on something that David said earlier about medicine, its history, eugenics, and what our system is built upon. And then I'll dovetail into that question around medical education. So I think that we can easily state that there are plenty of studies that show that patients of color are less likely to report having their pain controlled when in the hospital setting, whether it be for long bone fractures, which is something that our emergency departments get evaluated on. Post-surgical pain is something that is often a metric that people or hospitals use to assess the quality of care patients are receiving. And I think we got to take it back, not just to saying Black patients are less likely to receive pain medications, but really understand where this actually originated from. And this goes back to a time when we don't like to talk about in American history, talking about slavery. And there was a belief that there was less, that Black people perceive pain less. There is a famous story of a slave. His name was John Brown. He wrote a book about his experiences as a slave living in Georgia, being enslaved by a physician who, at the end of the day, after he was working in the fields, would be subjected to torture because this physician wanted to see where that different layer of skin was that made Black people more impervious to pain. And then you take that and you move this forward to a study that came out of the University of Virginia, where there was a perception that Black patients had less need for pain medications because of thicker skin. And so you have something rooted in slavery that has been ingrained in our culture, so much so that people who are now in medical school learning the art of medicine are going to be caring for patients who will then at some point go on to prescribe those pain medications. And so you have to look at it in its entirety. And we don't like to do so. We don't like to look at the history. And so to talk about how do we address this from a medical education standpoint, I think, we really have to think about, well, there's a couple of ways that we can do this. Number one, with medical education, one of the things that often happens is, we during Black History Month or during a particular course during medical education, we'll have that one standalone lecture where we talk about health equity, social determinants of health. And then that's it. Medical students don't hear any other discussions around this. And they hear it in the pre-hospital setting, but then they get into the practice of medicine when they're in the hospitals and they don't see it in practice because the physicians that are teaching them, the residents that they're learning under, have completely forgotten all of those important jewels that they were taught during their medical education experience. And so there's a disconnect between what we're seeing in practice and what the medical students are learning by those who are out in practice and what they're modeling after. I think the reality is medical education needs an overhaul where this needs to be, health equity needs to be ingrained within the culture of medical education. And what that means is when we're having a discussion not only we do talk about the disease and the pathophysiology, but we also talk about the structural racism that's linked to the disease. We talk about the inequities that are associated with the disease. We talk about the social determinants of health that are associated with the disease, so that our trainees, our medical students, get a full perspective of what this disease means and understand that it's not just Black people have higher hypertension rates or diabetes rates, but there's root causes to this. And we need to be thinking about addressing those root causes just as much as how to manage those patients who have those issues when they come to us in the hospitals, in the emergency departments, or in the clinics.
Thank you so much, Alden. Before we get to some viewer questions, I wanted to pose a question to Mary and Lori, looking at, institutional accountability. How do we make healthcare institutions and systems accountable for addressing medical racism? Go right ahead, Lori.
Sure. No, I think that's a really important question. And I think, as Dr. Ansel and Dr. Landry mentioned, addressing racism in healthcare, is something that's been on the agenda for decades, and progress has been limited, and now it's more on a national agenda. And so there's really an opportunity here. And so, so the important question is to ask ourselves as a society, how do we hold ourselves accountable? And part of the solution, to me, includes the who, and Dr. Ansel talked about it a little bit. It's, clear to me, you won't be able to improve healthcare without partnering with local communities. And, healthcare delivery systems have to partner with patients and community members in order to fully understand the needs and experiences of the people that they serve, and to become effective anti-racist organizations. It's critical to establish institutional accountability for addressing medical racism in healthcare. We're hearing a lot of systems level commitments, and that needs to be followed through with the development of accountability measures. For the work that, we want to support at the fund, we want to be able to support health systems focused campaigns that are trying to better understand what anti-racist health equity agenda looks like for a healthcare system. What are the metrics of success that can be deployed to track how they're doing, and institutional changes that can really eliminate disparities and inequities. At the same time, I also think it's important for financial and regulatory pressures, and that's why I think where the big P policy come in, that can motivate healthcare leaders to examine their internal cultures, attitudes, and beliefs, and really be pushed and incentivized to take remedial action. Part of the issue is healthcare organizations might not know where to start. And part of the issue is healthcare organizations may not be having these initial conversations to really understand how does racism manifest here, for example. And so some things that can be done: holding leaders accountable for fostering health equity, reviewing and revising mission statements, for example, developing inclusive recruitment policies. I think there's a lot of opportunities to be able to address this in a meaningful way. I'm excited about the work that I'm seeing coming out and seeing what health systems are doing, like what Dr. Ansel and his team are leading in Rush and other organizations. So there's a lot, I think, where health systems can start to learn from each other to move this work forward. And I think the payment and policy arena can help incentivize that.
Thank you so much, Lori. And Mary, I'd love to offer you an opportunity to, elaborate a little from the polling data. Is there anything that shows us when it comes to kind of additional insights into accountability, when it comes to holding, medical institutions accountable for addressing medical racism?
Yeah, great question, Nick. I think the most, at its most basic, what it shows us is that if you ask patients what their experiences are, they'll tell you. And the problem is not that this is not happening, it's that we're not asking people whether it's happening or not. I'm Mexican in my 35 years on this earth. And as a survey researcher, I like to put good karma into the world that I answer every patient satisfaction survey ever that is offered to me. And I've never, ever noticed anything remotely related to whether my ethnicity has affected my care. And I think, as Lori has said and others have said over and over, measuring really matters. And just the importance of, I think what this survey, among others, establishes is that if you ask patients, they will tell you, and we need to start asking them more regularly and publicly to hold ourselves as institutions accountable to what's happening.
I'm going to let Alden just piggyback off of that real quickly. Who needs to be hearing this? Is it leadership?
Yeah. Well, I think, Mary, thank you for sharing your experience as a patient, in the surveys. I think one of the things that goes along with that is oftentimes the right people aren't in position to ask the right questions. And when we have people of color in leadership positions, those questions are probably more likely to be asked. And one of the things that I've noticed, and this is definitely, as Dr. Ansel has pointed out, since, this sort of, we had all of these comments that came out from our medical institutions after the murder of George Floyd, and all these announcements of new chief diversity officer positions that were being put up all across the country. Unfortunately, what we're seeing is that those great leaders in medicine who are minorities often get pigeonholed into these diversity leadership positions. And I'm not saying that those positions don't add value. And I also recognize that I carry a title of Assistant Dean for Diversity. So I'm not trying to undermine the position that I hold. But what I would like to emphasize is that as we add diversity officers to the C-suite within these institutions, that's great. But let's also think about how we can get Black and Latinx folks to take on those chief medical officers roles, those chief financial officer roles, those CEO roles within institutions, because I think that will also help to shape the culture within an institution. And then it'll lead to better conversations with patients. It'll lead to us having a better relationship with our communities because we have diverse perspectives that are being represented in those C-suites, and not just a very homogenous perspective of how medicine could and should be run in practice. And I think that's why it's really important, and this is a shameless plug, Dr. Zephyrin, for the Commonwealth Fund Fellowship in Minority Health Policy based out of Harvard University and the newer version at Yale, because there are programs that are in place to prepare people of color for that next step into those leadership positions. And I think we have to really be cognizant to make sure that when we're reviewing applications for those next generation of leaders, that we're thinking about diversity as one of the things that we want to bring within our institutions.
Great. Thank you so much. I want to turn to some reader questions we have now. The first question is actually from Mary. It comes from Alice, who is asking about survey data. Alice wants to know, where can I find your polling data? And are there other resources I can consult that you would recommend?
Oh, excellent. So I believe there's a link to the studies on the forum website, or at least there will be after this event. And this was also, this poll became a research study that was published by Dr. Zephyrin and my colleague, Dr. Sarah Bleich, in JAMA HealthForum earlier this year. So we'll have all of the links to that available online. And I know my colleagues have so many excellent resources to share beyond this. So I have my own list, but maybe we can put them up afterwards. And if anyone else has ones they want to recommend right now, that's open to that.
I want to direct this next question from our reader Jonas about discomfort. I want to direct it towards David. Jonas asks, it's uncomfortable to talk about racism. Any advice on how to approach these kinds of conversations, especially if you are a white individual trying to be sensitive and feeling a bit uneducated about the issues?
Yeah, it's thank you for that question. I think it's uncomfortable to not speak about it, actually. We've just gotten, I realized I had to do a root cause analysis on myself. Why did it take me to get to 60 years old? I know I look a lot younger, but I'm older than that. Why did it take me so long as a leader, as someone who experiences this, who comes from a family who's survivors of the Holocaust? That's why I'm in this country. Who experienced those things. Why did it take me so long? So I did a root cause analysis. So ask yourself why 5 times you're not talking about it. So why, when you did that, I got to think, I'm in a room full of white people. Why would I want to offend them? And that became an unacceptable answer. Do you know what I mean? It's unpleasant for these white people. Why? But you realize there's white discomfort around this that's at the root of this. There are plenty of great books to read on this. White rage, white fragility, how to be an anti-racist. But I think it's an obligation, if we really can all agree that this is an affliction that's killing people prematurely, there's an urgency to fix it, then it's an urgency for us to get comfortable speaking about it. and finding our way. And honest time is that it's just an honest, open conversation. Maybe it's more complicated than that, but I think it's actually practice makes perfect. And then inquiring of people, like, well, how you experience the institution, looking at the data again and surveying people. So that's what I would say. Thank you.
Thank you, David. We have a question here from Erica, who asks about collaboration, and I'd love to pose this to Laurie. Erica asked, in what ways can federal leaders, academics, and those on the ground collaborate to address structural racism?
That's a great question. I think those collaborations are critical to moving the work forward. And I would also add community members to that too, and people with lived experiences. I don't think you can move this work forward without those collaborations. Otherwise, we'll end up with more of the same. So it's really important to include people with lived experiences, bring together policymakers, system leaders, and researchers to really help think through the problems and the solutions as well. Ways to do that or how to do that. I mean, I think any research projects that are moving forward should really incorporate the multidisciplinary perspective. The survey that that Mary talked about, it involved diverse perspectives to opine into how to develop the questions, for example. And I think as we're thinking about federal and policy solutions, policymakers really crave and require people with lived experiences to be able to inform that policy. Otherwise, we end up with policy that has potential unintended equity and inequitable impacts as well. So thanks for that question. I think those collaborations are critical to moving forward. And I think there's ways to incentivize those collaborations in terms of funding that type of work. And then for people doing the work, really also making sure they're looking around the table and seeing who's there and making sure that there's people with lived experiences.
Great. I mean, we have so many questions coming in here. Unfortunately, we won't be able to get to all of them, but I did want to ask one final reader question before we get to our wrap up about Robin is asking, where do we go from here? What can we do now? Robin says, targeting racism is important, clearly. But what other avenues or targets do you see as being worthy of attention and pursuit? Tackling racism will surely, quote unquote, take a while. Can we look toward other levels of intervention? And I pose that to whoever would like to answer it.
Well, I guess I would just jump in and say that, we can't just continue to go and sort of pick off the low-hanging fruit. We got to tackle the tough topics. And until our country comes to grips with its history of racism and its continued presence within our everyday society, we're not going to move forward. So I think, as there are other issues that can be attacked at the same time, but we have to make a cognizant effort as a country as we move forward to address racism at every single level, whether it's the policy level, whether it's at education, whether it's in the healthcare setting. We have to attack this head on, and everybody has to be on board if we're really going to make any headway in this issue.
Great. Thank you so much. I want to give every one of our panelists an opportunity to give our audience one key takeaway. And I'd love to start here with David. What would your one key takeaway be for the people who have watched?
Yeah, well, we've learned through all of our work through the years, if you can name a problem clearly, particularly if they're created by human beings, we can fix them. And a lot of the ways that this gets fixed is by blocking and tackling this sort of broadly around sort of pieces of this that you can really make a difference. And what we found in our work in Chicago, a great deal of optimism because people are feeling, yes, we're naming the right things, and they can begin to see the progress. That's to that last question. Sometimes it's in economics, sometimes it's wealth creation for employees, sometimes it's eliminating health inequity that's in front of you. So be optimistic. We can make this change, but we all got to do it together.
Thank you so much, David. Mary, if you would like to go next, what would your take-home message be?
Yeah, my takeaway would be that if healthcare institutions can start regularly measuring actual patient experiences for racial and ethnic minority patients in their surveys by adding as little as one question about racism, that would be a really good start to start holding ourselves accountable with other quality measures that are already tracked.
Thank you so much, Mary. Lori?
Great. I echo what David and Mary just mentioned. I mean, I think the one thing I'd like to add is that training is pivotal, and ultimately we need to build a more diverse healthcare workforce pipeline. I think that's really critical. Really ensuring how can patients provide routine feedback on experience of discrimination? How do we go beyond diversity training and have healthcare professionals be aware of their own discriminatory behavior and provide concrete actions against this? How do we expand our network of providers so that patients have choices within their communities to seek different types of providers, and diverse pipeline across all disciplines of healthcare, and really making sure that we have inclusion efforts to foster a racially sensitive culture.
Thank you so much, Laurie. And Alden, final words. Go right ahead.
So I would echo everything that's already been said, plus maybe continue on with Lori's point, just thinking about not just the pipeline into a career in health profession, but extending it further into leadership positions within healthcare organizations, because I really think that that is a great sort of next step for us to really think about how we evolve as a country addressing racism, thinking about structural inequities, and making sure that we have diverse individuals in leadership positions is going to be one way that we can do so.
Wonderful. This concludes the event presented by the Forum at the Harvard T.H. Chan School of Public Health in partnership with the Commonwealth Fund and jointly with STAT. I want to give a very special thank you to all of our panelists here, to Alden Landry, to David Ansel Rush, to Mary Feinling, and to Laurie Zephyrin. Thank you so much for joining us. I appreciate that. Should you need resources about this subject, please go to the Forum website at forumhsph.org. Thank you all so much for joining us today.